hallways are fine despite some fog and mist. I'm Jim Talamonte on AM 560 The Answer.
Chicago's Morning Answer continues next. And in our 1 hour heating and air conditioning weather center, we're seeing areas of morning fog, and then rain begins later this afternoon, a high of 50. Thunderstorms possible overnight. Some could be heavy, a low of 45. Currently 37 in clouds, along with some fog at O'Hare. Your next news update is at 7. Chicago's Morning Answer with Dan and Amy continues next on AM 560, The Answer.
This hourly segment is brought to you by On Target Radio. From firearms and Second Amendment rights to personal freedoms and government intrusions. Listen here Sunday nights at 9.
If you're looking for the latest news, insight into what it means, and the sharpest opinion, there's only one station in Chicago where you can turn, and it's this one. We're AM 560, The Answer.
Top of the morning, Dan and Amy, and the data. As we mentioned earlier in the show, Neil Ferguson, who is the lead author of that Imperial College London study that the media ran without providing contextual information about the modeling, like the premises upon which it was based, to feed hysteria and provide the justification for the philosophy that there's no such thing as an overreaction, which has been flatly rejected on this show, and all kinds of substantive examples. He revised down his projection, based on what England has actually done. And by the way, breaking news this morning, Bojo has tested positive for coronavirus, mild case apparently.
Yeah, he just tweeted out, over the last 24 hours, I've developed mild symptoms and tested positive for coronavirus. I am now self-isolating, but I will continue to lead the government's response via video conference. As we fight this virus together, we will beat this.
Stay away from Prince Charles. Revised down.
I wonder if they got it from each other.
500,000 deaths were projected in Britain by the initial model from Neil Ferguson, Imperial College London. Revised it down to 20,000 yesterday. Not to exceed 20,000 based on the actions that the UK has taken. Right. Because you have to inform your models with the real world evidence once the premises from which you based your modeling no longer hold. For example, the premise that nobody does anything, when in point of fact, a lot of people are doing a lot of things. But that level of texture won't be brought to you by the D.C. Press Corps, but it was brought to you by Dr. Deborah Birx yesterday at the White House COVID task force briefing.
I'm sure many of you saw the recent report out of the UK about them adjusting completely their needs. This is really quite important. If you remember, that was the report that said there would be 500,000 deaths in the UK and 2.2 million deaths in the United States. They've adjusted that number in the UK to 20,000. So 500,000 to 20,000. We're looking into this in great detail to understand that adjustment. I'm going to say something that's a little bit complicated, but I'm going to try to do it in a way that we can all understand it together. In the model, either you have to have a large group of people who are asymptomatic, who've never presented for any test, in order to have the kind of numbers that were predicted. To get to 60 million people infected, or of 6 million people infected, you have to have a large group of asymptomatics, because in no country to date have we seen an attack rate over 1 in 1,000. So either we're only measuring the tip of the iceberg of the symptomatic cases, and underneath it are a large group of people. So we're working very hard to get that antibody test, because that's a good way to figure out who are all these people under here and do they exist. Or we have the transmission completely wrong. So these are the things we're looking at, because the predictions of the models don't match the reality on the ground.
Indeed. For more on this, we're pleased to be joined by Eline Attenberg. She is served as a health policy advisor in Dutch and European parliaments, currently an assistant professor at the Larner College of Medicine at the University of Vermont, and Adam Atherly, professor and director of the Center for Health Services Research at the Larner College of Medicine at the University of Vermont, the Catamounts, if I remember correctly.
Oh, yes.
Very good. Doctors Altenburg and Atherly, thanks for joining us. Appreciate it.
Oh, thank you.
Thank you so much for having us.
So your reaction to Dr. Birx's reaction to the revision of that Imperial College London study that was given so much air?
Yeah, well, our point, the point that we've been making consistently for about a week now, is that the models themselves are fine, but we really lack the key inputs. Just as you just said, we need more accurate data. And if you look at the Oxford report versus the Imperial College reports, the question remains: what is the actual spread in the population? And we just don't know. It depends, and we don't have the right data to answer that question right now.
You know, and I would also add that if you looked at I think the Imperial College report has gotten a lot of attention, but there's also the CDC also did an analysis, and what the CDC found was, depending on what you feed into your model, you get a prediction of somewhere between 200,000 people dying and 1.7 million dying. And the trouble is that the variables that really drive those differences between a really, really bad flu season and a catastrophe just were not known at the time they were doing the models.
Well, I mean, there's others too. I mean, these 80,000 could lead to more than 80,000 deaths and overwhelm hospital capacity nationally as soon as early April. New research coming to us from the Institute for Health Metrics and Evaluation at the University of Washington School of Medicine, analyzing local and national and international level data. And I mentioned this, so there's another one to throw onto the pyre. And I mentioned this before, but 4 years after H1N1, there was a study that was published in a journal for epidemiology by a bunch of public health academics like yourselves, that reviewed 77 estimates of the case fatality risk from 50 published studies, about a third of which were published in the first 9 months of the pandemic. From the results summary, we identified very substantial heterogeneity in published estimates, ranging from less than 1 to more than 10,000 deaths per 100,000 cases or infections. That's quite a range. So how much should we be at this point in real time, as we were working with incomplete data, as you're describing, how much should we be basing, massive public policy decisions, both on the health side and the economic side, on projected fatality rates?
Yeah, instead of answering that question, I think that what we want to be talking about is what we can do right now. And what there's the story of testing, which is important. But the question I think that should be answered soon is, what type of data do we really want to be collecting? What do we want to spend our resources on the most right now to answer the most important questions? And I basically compare it to, let's say, the German approach and the Icelandic approach. In Germany, they say, we need to be spending, the majority of our resources to more testing, which is great. It's almost ideal. Iceland is probably more realistic in approach, in the sense that they say, well, let's say that we don't have the resources or the manpower right now to do massive testing. At best, we can do a random sample, and we can be testing a true representative portion of the population. And in their case, they started off testing about 1.5% of the population. And that would allow us to draw the type of comparisons that you were talking about in that other study. We would be able to extract the information we have from the sample to the real big U.S. population, and we could actually do the types of estimates that we so badly need to rerun these models.
But here's the problem.
And one of the problems we have right now is that Eline and I are both working a lot on the modeling issue locally. Is what we have is, we know who is tested right now, who's sick right now, who's in the hospital. And so what we have is, we've got very good information on who got sick 10 days ago, and then got sick enough to need hospital care. That's the number we actually have. But what we need to know, if we continue on this path that we're on, or if we change our path, how many people will be sick 10 days from now in the future? And we don't have that data because we're not looking for that data right now. The effort right now is really reasonably focused on treating the people who are sick, and less focused on trying to get the data we need to be able to make good policy choices.
Yeah, because
I was going to say, let me add one really important thing. The kind of pushback that we hear is we can't do that. It's impossible. And there's not even a debate about it. And when we think about it, it is very possible. The U.S. has a lot of standing samples across the country, big data sets like the MEPS, the Medical Expenditure Survey data, and similar existing surveys. We can use those to sample relatively quickly and not only test those people, but we have a whole bunch of variables about those same people, so we can actually make comparisons and compare apples to apples.
So here's the issue, and I'm all for what you just said. I've been saying that from the beginning. I don't understand why there's not the sort of sampling you would do in polling to get a representative distribution of the population so that you could make some reasonable projections within a 95% confidence interval. I agree with that. Here's what we got yesterday on this show from Dr. Gary Slutkin, who's a former WHO Director of Intervention, epidemiologist. He said, here's how we do testing. Because I asked him the same question that you're posing. He said, here's how we do testing. We do people presenting symptoms. Then we do contact tracing, testing of those they came in contact with to the extent we can determine. Then frontline healthcare workers, and then the general population. And, and he basically said, with 50,000 tests a day, maybe ramping up to 75,000 tests a day, we're not there yet where we can start to work down that progression. And I don't know if that's a sensible progression or not, but he said that this is how we handle viral outbreaks in terms of the testing protocols. And so it seems like some of the public health professionals that are the modelers and the statisticians need to get with some of those that are the managers, like Dr. Gary Slutkin.
Yeah, no, I think we've run into that exact same discussion. And one of the things about most of the models that were used to sort of make this decision to close down the economy is that they were not thinking about the economic effect. And how do you balance the cost of the program with the benefits of the program? We make decisions to either spend money or not spend money in a way that costs lives all the time. I mean, we do that as a society. We do that as individuals. We do car safety. We decide what drugs we'll pay for. We sort of make these decisions both at an individual and a policy level to accept more risk in order to save money very, very often. What's unique here is, to my knowledge, we've never had a trade-off with the magnitude and the sort of scale that we're talking about now, where you're talking about trading millions of lives for trillions of dollars. I mean, I think that's kind of unprecedented. And so when you think about the typical models you use when you think about an outbreak like this, you're not talking about spending $4 trillion to prevent it. So usually the economics of this aren't built into it. And, again, NBR, the National Bureau for Economic Research, has done some very nice modeling sort of saying, how do you bring the balance of thinking about the economic impact with the health impact in together?
Hi, it's Amy. Can one of you explain about flattening the curve? I mean, is this an idea or is this based on data?
Yeah, as we put in our article, or one of the articles we published, the actual figure that went viral, let's say, and there's different versions of it. Obviously, you have the cartoon version, and then there's, all the other versions. But all those figures are based on hypothetical data. They're not based on actual calculations, but they're very intuitive. I mean, everybody understands, and this gives me an opportunity to stress, we both find it pretty hard that, to keep stressing and talking about data and statistics, because we understand that people they have fear, and, Adam and I have moms too, and we worry very much about them. But especially for my mom, I want a discussion about those types of graphs that are based on actual data, and so that we can have a debate on how flat that curve needs to be exactly. Because I think initially everybody accepts the intuitive idea about flattening the curve, but we've reached a point where we need to have a debate about how flat that curve needs to be.
That's a great point. She is Eline Attenberg. She's served as a health policy advisor in Dutch and European parliaments, currently an assistant professor at the Larner College of Medicine at the University of Vermont, and Adam Atherly, professor and director of the Center for Health Services Research at the Larner College of Medicine, also at the University of Vermont. Doctors, thanks so much for joining us. Appreciate your insights.
Thank you for having us.
Thank you.
And they joined us on our turnkey.pro answer line.
It's what Chicago is talking about. It's Chicago's Morning Answer with Dan and Amy on AM 560. The Answer.
The Lou Dobbs Financial Report is brought to you by Signature Bank, helping local businesses succeed. Visit signaturebank.bank for your commercial banking needs.
I'm Lou Dobbs. House Speaker Pelosi predicts strong support for the relief package today. The NCAA slashing payments to colleges and universities, and Lowe's hiring 30,000 people. Those stories next.
The coronavirus is wreaking havoc here in the United States and across the globe. The stock market is plummeting. Sports leagues are suspending their seasons. Schools are sending students home, and the entire U.S. economy has been destabilized. Many experts say this is just the beginning. This is a devastating risk if you're heavy in stocks with no safeguard. Wise investors know to hedge against stock market collapse by utilizing physical precious metals. Noble Gold is a leader in this conservative